Happy Wednesday, start of October. My name is Liz Buckle, and I'm going to, I think for the most part, be walking you through this webinar where we will give a pretty decent overview of what CommonWell is and a little bit about our history and where we're going. First, I will give you a little bit about myself and our agenda. I am the Director of Product here at CommonWell. I've been here for about 5 years. Started out as a contractor in interoperability and kind of moseyed my way into full-time employment here at the Alliance. Before that, I worked at an EHR company and have been in interoperability for over a decade, which is crazy to say out loud, but really believe strongly in the mission and vision of the Alliance and excited to share with you where we are, where we're going, and some more information. So a couple of kind of high-level sections, but it all just sort of flows into one. Today, I'll give you an introduction to the Alliance. We'll talk about how we operate a national network and what our core services are. We'll talk about TEFCA, obviously, and being a qualified health information network and how that works. And then we'll also talk about how you can get connected, what resources exist out there, and what next steps look like. So who are we? So CommonWell is a national network for query-based exchange. We were founded over 11 years ago. And our alliance is a membership-based organization and a trade association. But really what that means is we operate as a consensus building organization within health IT. So we have many health IT vendors that have various types of products and solutions out in the market that come together under the CommonWell Alliance to help promote interoperability at scale. We are a 501c6, so we are a not-for-profit organization. And through our 11+ year history, we've been dedicated to making data available, breaking down silos, and ensuring that patients and providers are able to access that data regardless of where their past care has occurred. We have a small but mighty team. Paul Wilder is on. He's our executive director. He also has been here for about 5 years. I already introduced myself briefly. Courtney is our marketing manager, so all things communications and marketing is coming from her. And then Marina handles kind of everything under the sun when it comes to the Alliance comings and goings. She's really your go-to person for anything here at the Alliance and can make sure that you get to the right place. We also have a technical service provider. We actually have two. We are in the process of winding down our contract with Change Healthcare, who is what we call now our legacy service provider. And we have been up and operational with our new service provider on what we are sort of internally calling our 2.0 platform, which is LK. LK has 20+ years in the interoperability industry, starting out really focusing on labs and orders and all of that integration, but also data migration, and is now our technical service provider and operates our TEFCA enabled platform. And then we also have some additional contractors, legal, bookkeeping, operations, that sort of thing. So historically, I've said our vision and mission have been unchanged over the past 10+ years. And that still is true. We have made some slight modifications to these statements, though. So from a vision perspective, we still believe that health data should be available to clinicians, care teams, patients, and we'll be extending that into other realms within healthcare, regardless of where that care has occurred. I always like to share my own story. I have lived in 7 different states, I think, if I'm counting correctly. I don't think I've moved recently. 7 different states. I've received care in all of those states, and many of them, as an adult. I've had diagnoses that are critical to my ongoing health and well-being. And, that doesn't inherently mean that I know exactly where that care was or what the current name of that provider organization is, but through CommonWell, my current providers and care team are able to access all of my data, both the most current and historical, kind of regardless of where I've been nationally. And then our mission is to break down barriers. So we really were started 11 years ago by EHR vendors to do this very thing, recognizing that interoperability and interfacing is difficult, and to do it in a point-to-point manner, is difficult from a contracting perspective and also a technology perspective. And so we wanted to break down some of those barriers to help foster this national network. And this year have become a qualified health information network, which really is just an additional attribute to what we've already been doing for more than a decade. So I want to, before we get any further in, I want to share this video with you. And let's see if I can do this somewhat effectively here. But I share this a lot when I do these sort of presentations and when I do our new member presentations, because when we think about what is CommonWell, this video is made many, many years ago, but still holds very true today and is very powerful today. So I like to share this. It's only 2 minutes with you guys. And I think, let me just triple check that I got to share with sound. So I do that correctly. All right, you guys should be able to hear. So there's a couple of things in this that I sort of like to call to the forefront, and this was made a decade ago. I'm just going to reshare while I'm talking. Couple of things that I like to call out from this video. Obviously, it's powerful to think about, data access at a national scale. It's something that today, more than a decade later, we're sort of getting to the point where it's like, okay, that makes sense. We should all be doing that. Hence, the introduction of the Qualified Health Information Network, and TEFCA, and creating a single on-ramp, and all of these things are concepts that CommonWell has been championing for more than a decade. In addition to that, I also like to note that CommonWell is not a standards development organization, and we are not an SDO. We leverage existing technologies and existing standards and help others come together and leverage those standards to be able to do this exchange at a national scale. Some of the logos you see, you saw on the screen, are outdated, but we have those members plus. I think we have like 78, 79 members today, the majority of which are connecting and sharing data on the network. So it's really been a community-focused, community-building alliance, and continues to be that way today. And that is a nice, somewhat unintentional segue into what our culture is like here. So historically, the Alliance has been all about collaborating together. There's been this ongoing saying that has, I think, has been said at every, annual meeting that we've had, which is we encourage our members to leave their corporate badges at the door and come into this community with a shared understanding that we're all here for, interoperability for the greater good. We also, more recently have really doubled down on our emphasis around scale and trust and stability ever more in this type of environment where, trust and stability, specifically have been challenged. We already have a really significant scale today where, we're seeing millions of transactions, millions of documents, a day. I think it's between 30 and 40 million. It could be more, I don't know, a day going through the network. So the scale exists. The data is flowing. The data is moving. The trust has existed for quite some time. As new entrants come into play, the trust, has to be maintained. And that's something that we have been really committed to and focused on and continue to be, both within our own community and also by extension into the other frameworks where we participate. So a little bit about our history, and you kind of saw that a little bit in the video that I just played, but we were founded in 2013 by 7 health IT companies, notably Cerner, now Oracle, Athena Health, Greenway, all, founding members that are exchanging data today. These were all competitors, and I used to share a picture of some of the people, but that picture is kind of outdated now. But these were competitors in the space, to the point where when they made this announcement live at HIMSS that year, a few of them had to be like intentionally not seated next to each other because of how fiercely they competed out in the market. But even today, these same competitors, and even more so, come together under this shared vision of breaking down barriers to access. We have a really diverse membership and has been growing. So obviously EHR vendors, but we also support consumer applications and personal health records. We support, a variety of different health IT solutions that are serving providers and patients out in the market. And we have our services in, all 50 states, including DC, including Puerto Rico, and U.S. territories. We collaborate more than ever, I would say, with our industry and government partners. Paul, our executive director, and I are regularly, weekly, sometimes multiple times a week, communicating with other industry partners and, with the ONC, now ASTP, on initiatives, obviously including TEFCA, but beyond even just that. So this, and I should say, usually we'll get a question in the chat around, are these slides going to be made available? Because I think in every webinar that is a question. And yes, they will be shared with you after the call. I'm not going to read this entire slide to you, but this just kind of gives you like some key points, key milestones that we've achieved over time. A few that I'll call out. We were announced and formed in 2013. We didn't hire our first full-time employee until 2015. And that first FTE was the executive director. And that person served as the sole FTE up until Paul and I were here together in, what year was that? 2019. What that means is that the alliance was able to grow pretty dramatically over the course of 5, 6, 7 years, solely because of the community that founded it and supported it and sustained it. Our members come and show up and participate in our committees, wrote the specification that we, still have today, added new use cases, enhanced new use cases, tested with us, pushed us to go further, be better, solely based on volunteers from our community. Now we have more staff in place and we're able to relieve some of that burden from our members, but we still engage them at every turn. Just 2 hours ago, we were on a call with our members in our policy and use committee talking about important topics, talking about adding use cases and how to do things the right way here within CommonWell. We also, one thing I want to point out, we added the patient access use case back in 2016. So having patients be at the center of everything that we do has really been a driver for many, many years. It's been something that within the industry has seen, challenges when it comes to adoption, but it's been something that here at CommonWell we've been working to promote very heavily, and we do have adoption of the patient access use case today, and pushed for that same adoption in TEFCA. What else do I want to call out? We, in 2022, we demonstrated Fire at Scale on the HIMSS Interoperability Showcase floor. That was very exciting. And we leveraged what is now referred to as SARA, or the Fast Security IG. Some people also refer to it as UDAP, right there on the HIMSS floor, proving that we can come together and do Fire at Scale in the same way that we do document exchange at scale today, where there's trust established between parties, and there's not a need for point-to-point contracts, point-to-point negotiations. We also had a Fire Connectathon that year internally just with our members, and we plan to have another one soon. And we announced our intention to become a QHIN, which we achieved designation at the beginning of this year. And this is just sort of a snapshot of our some of our key metrics. You can see at the bottom some of the different types of healthcare settings that are connected to the network. Obviously, we have hospitals and health systems and ambulatory clinics, but we also have labs. We have patient access, consumer applications, pharmacies, post-acute, long-term care, telehealth, home health. It really runs the gamut, and more are welcome. I think, we'd love to see further engagement for labs and pharmacies and specialty types of organizations as well. We have over 37,000 provider organizations connected, which have a representation of over 246 million uniquely identified human beings inside of our MPI. We'll talk about our MPI here shortly. And that equates to over 8.8 billion health records retrieved as of the end of September. So at our core, we believe that, breaking down barriers, like I've said a few times now, is really integral to enabling exchange at a national level. And we think that given our experience and our current national scope, that we are uniquely positioned to help, bring national interoperability forward. We have a relatively strong voice within the industry. We participate, across different types of stakeholder groups, and continue to talk about the importance of bringing interoperability from just being widespread to ubiquitous. It's automatically baked in. Everyone has it. Everyone knows it and uses it, and can do so in a meaningful way. We're also community building. I've already sort of touched on that, so I'm not going to go into a lot of detail on that. But then the third thing is that We are visionary. So some of the things actually that you'll see that exist in TEFCA today came directly from the CommonWell specification. So when we talk about patient access, for example, CommonWell has required that patients or consumers using an application go through an identity verification process. And we've required that for many years now. That's been adopted into TEFCA. There are some other components that have gone directly into initiatives like that we sort of put our foot out there and said, hey, we think this is the right way. We were able to prove that it was the right way. Where we have had experiences that didn't go in the right direction, we've taken a step back and, done some internal investigation and bring it back in a different way. So we're continuing to try to push the envelope when it comes to new use cases, but really also just enhancing the use of the network and creating those efficiencies. This is what I like to call our NASCAR slide. So this is sort of all of the logos of the members that exist today. The Alliance is open to all organizations that are aligned with our vision. We, have health systems that are general members that may use their technology to connect. We have nonprofits, we have government agencies, and then a whole bunch of health IT vendors that do technically connect into the network. There are two different types of membership. So if you're going through our website, you're trying to figure out what makes the most sense for me, this is the way that I think about it. If you want to participate within the Alliance and get an insider access to what we do and our committees and our internal documentation, then you will want to become a general member. General members have all of the benefits of membership, have a voice within the industry, have cross-marketing opportunities, but they do not technically connect to the network. Service adopters do. So if you want to connect to the network, exchange data, add your clients to the directory, that is the service adopter option. One thing that I do sometimes recommend to people who are interested in joining but may not be sure exactly of the right time to embark on the technical journey to connect is to become a general member first and get inside and get access to everything that you need, begin to attend some of our committee meetings, and then upgrade, so to speak, to become a service adopter when the time is right for your organization. So that's always an option as well. So our connections are not just inside of the CommonWell network. And sometimes I refer to this as intra-network. So inside of CommonWell, we have a whole bunch of connected service adopters that are live and exchanging data and doing so in a brokered manner where they connect in once to us, and then we handle all of the transactions that are necessary and all of the connections that are necessary both inside of CommonWell and with external frameworks. We are connected to Care Quality as an external framework and to TEFCA as an external framework, and our members enjoy the benefit of both. There's no special technical effort that is required of our members to connect to external frameworks, nor is it required. Although we see, for the most part, pretty much everyone chooses to connect to the external frameworks because, why not get access to more data? There are some additional flow down terms that come into play, and I'll briefly touch on those when we get into some of the resources that we have available on our website. But CommonWell, as the MPI, RLS, and data broker, we handle all of the connectivity and transactions on your behalf, reducing that technical burden for you. So let's then get into our core services. So when we talk about our core services, we really are talking about three things wrapped inside of a trust network. And they're laid out here in a linear manner, but I really see them as three things: an MPI, master person index, a record locator service, a data broker, and all of this exists and functions inside of a trust network. So we'll talk about each of these things and how they work together. So first, let's talk about a master person index. So I'll probably just call it an MPI for now because there's a lot of words to say. Our MPI collects patient demographic information. So every connected organization to CommonWell feeds in patient demographics. When a new patient comes in, when an update happens to a demographics, we receive those in via a REST API or HL7. And what we do with that is we create an index. So we have at the highest level a person, a human being, Liz Buckle or Jane Smith in this example. And then underneath of that highest level in the hierarchy are all of the individual instances of that patient and where that patient has been seen. So what we call a local patient, who has been seen in this instance, the local patient Jane Smith, who has been seen at Mercy Medical Center or at the pulmonology clinic. And we index and keep all of those records of who the patient is and where they've been seen, historical addresses, name changes if people get married, and so on and so forth. Our modern MBI today and our new platform relies on a significant amount of automation. Historically, CommonWell relied on end users to do a lot of the, asserting that patient records match. But over time and through a significant amount of data analysis, we've been able to come up with a really strict matching criteria to enable the MPI to do a lot of self-functioning on its own. And we still allow for our members to review that and make corrections as needed. But the MPI is able to deduplicate and merge person records so that there's consistently just one person record per human being. So Liz Buckle in the MPI should only ever have one person record because I'm one person. And all of my patient records should be able to be combined together in the index. We also have simplified how our MPI works. So we've reduced the number of APIs that are needed from our legacy platform into our new. We've strengthened the algorithm that's used and allow for our members to have as little manual interaction as they see fit. And then it's also highly reliable. So we have enhanced analysis tools that our technical service provider uses to ensure that the algorithm is working appropriately, that we're avoiding false positives, that we're minimizing false negatives as much as possible because we want to have those patients matched. And making sure that we're presenting patients that maybe fall below that automated matching threshold back to an end user to in a probabilistic way to adjudicate them. So from my perspective, an MPI and an RLS really are two pieces of core functionality that have to work in concert with each other to enable interoperability at scale. I don't see a way to have a comprehensive interoperability at scale solution without having a strong MPI and RLS. So an MPI complements an RLS because it has the patient information and the care location information. So in the CommonWell MPI, you're able to see that Liz Buckle has been seen at Wellstar Health System in Atlanta and also Novant Wilmington Health in Wilmington, North Carolina, all within the index and other care locations, but just as an example. And you're able to see all of the instances of that patient inside of the index. But that is important because we use that information to know where to query. So the MPI and the RLS are really foundational requirements for us to be able to know where to query for clinical data. So it matters because we get a comprehensive list of patient care locations. We don't have to guess. We don't have to rely on geographical boundaries. We don't have to rely on a region or a state or a zip code. We know how to deduplicate and merge patients that we're always coming back to that single human being at the top of the index. And we can respond to a single query that comes in to the network for Liz Buckle with a comprehensive search result every time. We also, it allows us, again, like I said, to not rely on geographical boundaries. And this is, again, inside of the CommonWell network. It allows us to not have to return an incomplete list of patient care locations because we were limited to a certain geographical boundary. And it also enables us to not spam endpoints unnecessarily with queries. Because if you think about, well, I'll get to that in a minute. I'm going to go down a story here, but I'll get to that in a minute on what that really means. So it matters because when you have one comprehensive result, you have certainty that, everything that this network knows about, know about when it comes to where a patient has been seen. If you think about, for example, my situation where I've lived outside of Atlanta, I lived there for many years, had a lot of care there, a lot of important care, had children there. Now I live in Wilmington, North Carolina. Doing a geographic search around my current zip code, 50 miles around my current zip code, is inefficient and ineffective. You're going to query probably more than 100 different care locations around me, but I only see 2 providers here in the Wilmington Health area. So if you query 100, but I only see 2, then that's 98% of the time you're getting a no patient match response or no patient found response. That's not efficient or effective. But in addition to that, you're also leaving out all of the care locations that I've been seen at in Atlanta, which have important information on me that you may want to know about, especially if you are my pulmonologist, for example, and want to look back at, all of the history of my asthmatic, condition. Or if you want to see my, all of the information that you have to see from my OBGYN and all of my pregnancy information, which may be relevant for future care. So that's really the key in why we feel like the RLS is a critical component to national exchange at scale. Another real life example that actually, happened to our executive director. We changed the name to Sam for whatever reason. But this is a real life example of something that happened recently within the past few years. So this person lives in Hoboken, New Jersey, right outside of New York City, but was visiting his father about 73 miles away on the Jersey Shore and had a significant asthma experience that required going in an ambulance to the emergency department. I don't know if, those who know about asthma, it can be very difficult to speak. And a lot of times when I'm personally having an asthma attack, I will completely lose my voice, not only struggling to breathe, but just have no voice. It was critical that his providers in the emergency department be able to access his data. And then even more critically, it was important for his pulmonologist back home to be able to see this, acute episode that took place. If we were using a standard geofence zone around 50 miles of his home address, neither of these things would have been possible. His emergency department provider would not have been able to see what medications is he taking. This is really important. What, conditions does he have? Oh, he already has an asthma diagnosis. This is what he's taking. And then similarly, his pulmonologist back home would not know that he had this acute encounter. And so we, from day one of CommonWell, we've always believed that access to data should not be limited by a geographical bound. And that brings us to the data broker. So once all of those things are true, once the MPI is connecting with the RLS and we have that full index and know where the patients are, then the data broker job is much simpler. So a single query is able to come in to CommonWell where, do you have data for Liz Buckle? And the data broker then is able to go to all of the care locations where we know Liz Buckle has data and ask for that data. The data broker supports both IHE, integrating the healthcare enterprise profiles, which include XDA query and XDA retrieve, and we support FHIR, R4 document reference, and binary resources. So our members can connect to us in using either technology method. We don't require that you do one or the other. A lot of the time, pretty much the majority of the time, our new members are connecting to us using Fire. And then you can retrieve what you want. So we return, an aggregated list, including the metadata of the available clinical documents. And then the system that initiated that request can choose to return all of those or just a subset of those back into their system. And like I said at the beginning of kind of this core services section is that we have all of this existing, and the reason why it's been able to exist and be successful is because of the trust that exists here within the network. So not only do we have governance and policies and procedures, which you sort of expect anything, any entity like CommonWell to have, but we also have a standard agreement that our members agree to. We have a standard end user license agreement that gets flowed down, a similar model to what Care Quality and TEFCA use today. In addition to that, we never store clinical data ever. We are not able to see the clinical data. So a lot of times we'll get questions that say, hey, how often do you get labs included in the documents? That's something we know anecdotally. It's not something that we look at and analyze ourselves because we don't open the clinical documents at all. And then one of the most important components to establishing and maintaining trust is that the systems that are connected to the network today and that are allowed to execute requests against the platform are certified by CommonWell. So they have to go through a testing process in our integration, our test platform, and they have to go through certification and provide evidence of conformance to our specification and all of the, policies and procedures that I referenced. They have to prove that they're adhering to those before they're given access to the production system. So I've mentioned a little bit about Fire when it comes to document exchange. So we are moving into more of a Fire realm. We have the document exchange via Fire, and it's been live for a number of years now. Like I had mentioned, most of our members that come in today do exchange, initiate, and respond using R4 document reference and binary resources. This allows for a really easy onboarding and implementation process, and you get access to the full CommonWell network because we have the data broker. Even though there are other entities that exchange using XCA, we have a transform in the middle that allows for XCA and Fire to kind of go back and forth. This also allows for ease of access to Care Quality and to TEFCA. Beyond that, we have been testing discrete data exchange in Fire. I mentioned before that we tested it a couple of years ago, and we are now testing it again in our new platform, which is very exciting. So in the discrete data exchange world, CommonWell as an MPI and RLS act as the Fire directory. So CommonWell is the directory. We know where the patients are, and we can return to you the Fire endpoints where there is patient data. From there, the remainder of the transactions happen outside of the CommonWell network, directly between the Fire client and the Fire server. And we require that connectivity for registration, authentication, and authorization follow the HL7 security implementation guide, or what we now are referring to as SARA, SSRA. Alongside of that discrete data exchange via Fire, we are on top of that testing individual access services via Fire in TEFCA. So we're in the preliminary phase of testing that with one of our members and two of the other QHINs, and we'll be really excited to report some updates on that in our upcoming Fall Summit, and then hopefully also at the ONC ASTP meeting in December. CommonWell recently became a data usability supporter. Many years ago, CommonWell and Care Quality decided to form a joint document content work group where we worked together with our members, and had both of our communities coming together to say, hey, we've got this data exchange up and going, but we could do better when it comes to the actual content and format and usability of the data that's being moved, within our pipes. And an evolution of that, moved from Care Quality into its parent organization, the Sequoia Project, where they founded the Data Usability Work Group. They have put out a implementation guide about 2 years ago, and they're in the process of putting out an updated version of that implementation guide. And CommonWell has recently become an official supporter of the data usability taking root movement. Another kind of foreshadowing, we will be digging into this deeper at our annual fall summit coming up next month, which you're all invited to come to. And we'll talk a little bit more about why data usability is important and what some key functions should be to kind of take the next step forward. Additionally, all of our members have access to a readiness checklist that they can use with their clients to see how well am I doing in this kind of data content usability ecosystem. I've talked a little bit about the RLS and why it's important. We have this additional video. I'm not going to play it for you guys today, but in the content that you receive after, this will be in there, and you can just click on the YouTube symbol to play right here, and watch the video yourself. It's very short, but it gives you a nice overview of the significance and importance of the RLS, and how it is really critical to the success of TEFCA. So I'll talk a little bit about TEFCA, and what it is and how we are participating. So the Trusted Exchange Framework and Common Agreement came out of the 21st Century Cures Act back in 2016, and it went through a few iterations before it actually really came to fruition about 2 years ago. And what it did was it said that the federal government requires that the ONC, the Office of the National Coordinator, create this trusted exchange framework and have a common agreement that health information networks can sign to agree to the same terms, agree to the same rules of the road, and create really a network of networks. So we already had CommonWell out there doing its thing. We had eHealth Exchange out there doing its thing, Care Quality doing its thing, and regional HIEs coming together, already sort of trying to collaborate even across state lines, which has been fantastic. And so it's really become just an evolution of what was already happening in the market naturally, but now with defined rules of the road. And in addition to that, it seeks to engage other types of exchange beyond just provider to provider exchange for treatment. So CommonWell has become a qualified health information network, and we leverage our highly efficient MPI and RLS to be able to do so. So we go and query all of the other QHINs and be able to remember that information when we do so. We like to talk about how we're uniquely positioned because we really see the QHIN model as an evolution of what we've been doing for the past, over 10 years. And what we tell people often, in panels or when we're speaking publicly is the scale is available today. You don't have to wait for TEFCA to itself be at scale, which it's not. It really just started seeing exchange in the past few months. You don't have to wait. You can access the scale that is available today via the CommonWell network, and then we also give you access to Care Quality and to TEFCA. I wanted to talk a little bit about the permitted types of exchange and how those work. There's not a fantastic way to represent that in just one slide, so I'm going to have to do a voiceover of exactly how to interpret this slide. The check marks are relatively self-explanatory. So the blue check marks. So for treatment exchange, provider to provider exchange, defined by HIPAA, CommonWell, Care Quality, and TEFCA all permit them and require them to be done. Patient access, the ability for a consumer or human being to use an application to query the network. That is something that CommonWell supports today and something that TEFCA supports today. Care Quality does have it in their implementation guide, but we are unsure if it's really being used to any degree there. Payment, so under the kind of HIPAA covered entity type of exchange for, primarily payers to query for payment-based activities. That is something that is coming soon. So we've been working on it for some time. We're trying to align as best we can with TEFCA, just so that for the majority of the time, the requirements are the same. And TEFCA also has been working on it for some time. It is permitted in Care Quality, but again, unsure if it's really being adopted there. Healthcare operations, we just had a meeting earlier today within our community on putting some of the, updated or enhanced policies and procedures into place to support healthcare operations. We have the ability to support the key TEFCA components of that inside of the network coming out this month in our new platform. And TEFCA also supports it. Public health. Kind of same thing. We are working on supporting it, currently supported by TEFCA. There is some exchange happening there, but relatively limited. Government benefits determination, so things like the SSA and people who want to seek, disability benefits through the SSA or the VA, and being able to collect the necessary medical documentation to receive those benefits. That is something that we also are in the process of working on, and so is TEFCA. So TEFCA permits this type of exchange today, but we don't have a standard operating procedure to do it. So it's not something that is being done quite yet. And then HIPAA waiver use cases. So outside of these that I've talked about and outside of, your standard TPO covered entity type of exchange, there's also the ability to have a patient sign a HIPAA waiver and say, release my information to the party that I've listed here because I've given authorization. That's not something that we support yet, and the other frameworks don't either, but it is something that is on the radar. And I should have also included here clinical research. So clinical research is also something that has been talked about, is not currently supported yet, but is something that is being talked about within these kind of joint communities. So really, as I'd mentioned, the time is now. You can get access to the scaled community now. You can prepare for TEFCA. If you already are a care quality implementer, you can get ready for the shift to primarily having exchange be in TEFCA over the course of the next year by joining CommonWell at this point in time, getting into our integration environment, going through the testing process. We also have an exclusive offer. We are willing to offer our services for free through the end of any current care quality implementer's term. So you have to communicate that to us and let us know when that is. And we will serve as your implementer and also enable you for TEFCA. So there's contact information at the end of this for how to get in touch with us there. From a high level, people ask about what are the steps to, connect to the network? We have a specification that I'll share with you. You would sign the agreements, pay your implementation fee, connect to our integration environment, complete the test plan, and then provide testing evidence, go through certification, and then you get access to the production system. We have some key resources that are available on our website that I definitely encourage folks to take a look at. We have a resources page that has the videos that I've been sharing and other documentation. We have a news section that has both our blog and news posts that you can take a look at. And then our Who is Connected is our provider site map. So you can see what provider sites are connected, and you can download that into a CSV or Excel file. Also available on our website are our membership agreements. So we have a baseline membership agreement that both membership types sign, both general and service adopters. And then we also have a member services agreement that just service adopter members sign. Both of those are available on our website. We also have our end user license agreement on there and the TEFCA flow down terms as well. Additionally, our specification is public and is also on our website. So you can see it has two parts. The services side is the more technical component, and then use cases are use cases. And then we also have our specification license, which allows for our members to use our specification to connect. Our members that participate within the Alliance are able to participate in our committees, and oftentimes we'll have work groups that spin out of these committees as well. So right now we're looking at spinning back up our fire work group out of the technical committee. But right now we've consolidated these down to just these three committees. So a technical one that really focuses on the services specification, where we're adding new components or making changes to that specification. We want to make sure that that is broadly communicated within the Alliance and that our members have an opportunity to weigh in. Our Policy and Use Committee talks about all things policy related and how those relate to the requirements in our use cases. And then marketing is marketing. We meet together as a marketing committee to talk about not just what's going on with CommonWell, but also what's going on within your own organizations and how we can help kind of promote each other. Members that are signed up for CommonWell get access also to an internal community that we have built out on SharePoint. So there's a lot of information there. We share release notes. We have all of the committee documentation. We have reports that get posted there. We have a discussion board, network updates, really anything under the sun that gets communicated out to our members lives in SharePoint. And then I also wanted to invite anybody on this call who is interested to join us at our annual Fall Summit. So every year we host a Fall Summit where we get together and talk about what's going on within the Alliance, what's going on within the industry. It's usually a very energizing event. As a product manager at heart, it gives me a lot of energy to come back with great ideas that I can then turn into roadmap plans. This year is a little bit different. Historically, it's been a members only event, but this year we are inviting anybody kind of in the health IT space who is interested in learning more, participating, potentially becoming a member, not required, but you're welcome to. And we are expanding the types of speakers that we have and the topics. So you can see here a snapshot of some of our featured speakers. We have not one, but two keynote speakers this year. We have panel discussions that'll talk about TEFCA. We will dive into data usability. We will be announcing a new CommonWell Marketplace sneak peek at our Fall Summit. We'll be talking about fire and the work that we've been doing there. You'll hear about our roadmap and what we've built with our new provider and where we're going. So it's really a very immersive experience. And we invite you to participate. And we also will be sending you a registration discount code after this session if you're interested in joining us. So if you're interested in becoming a member, you can fill out a contact us form on our webpage. If you scroll to the bottom of our site, you'll see where it says contact us. You can fill that out. That comes directly to me. Or you can email us at membership@commonweallalliance.org to discuss anything under the sun that you might be interested in learning about CommonWell. And I think with that, I'll leave this up here. Actually, I'll go to the last one as the same email. We can take any questions in the last few minutes that we have.
Your questions have to go in the chat, or is there, how does that work, Liz?
I believe that you can enter it in either the chat or the Q&A. I don't see anything in Q&A. Hopefully you have the ability to raise your hand. We can call on you if you would like. Yep, we can allow your mic if you would like to ask a question.
Oh, there's one.
All right, let's allow your mic.
Hey, hi Liz, thanks for unmuting me. Thanks for the much detailed demo. Quick question, we are an existing CommonWell participant, and if we plan to participate in a TAFECA QHIN, one of the statement was like you will be onboarded based on your care quality term, right? I did not get that part. Can you elaborate more on that?
Yeah. So the offer is for current care quality implementers if they're looking for a home in TEFCA and they want to join over here, we can become your care quality implementer and onboard you to TEFCA. The offer is that we won't charge you a membership fee until your term, your next year term with care quality is complete. And really, we're doing that because we recognize that joining sometimes in multiple places can be cost prohibitive, and we don't want that to be a barrier for people who are looking for a home in TEFCA. We also know that, Epic's made a recent statement that they plan on moving, all of their organizations to TEFCA by the end of 2025. We expect to see care quality go through sort of a wind down process throughout that time, and we don't want connectivity to be lost. So for anybody who's interested in having CommonWell be your care quality implementer and giving you access there, and also giving you access to TEFCA should you want it, we have this offer for existing care quality implementers. We won't charge you membership fees until your term in 2025 runs out with care quality. Hopefully that makes more sense.
Yep, makes sense. And that onboarding will be with your new vendor you mentioned, right?
That
Not
is
change
correct. That is correct.
Okay.
Everyone who comes on board today only onboards with our new member. The onboarding process is very streamlined. You have a technical project manager who is assigned to you, who helps you every step of the way and answers all your questions. If there's any issues that arise, they get those resolved relatively quickly for you. So it's been a really fantastic experience so far.
Okay. And is this offer applicable for existing CommonWell care quality participant too, or just for a new one?
New ones. It's currently limited new ones, right? So Liz alluded to it. The main concern originally was an acceleration of a movement to TEFCA and away from care quality, right? So we've been talking to care quality implementers, they're kind of thinking what they're going to do. And we said, look, my direct advice is if your intention is not to be a QHIN, then we recommend that you find a dual homed entity as soon as possible, something that is both an implementer and a QHIN. We actually weren't originally advising that it should be us, but we said we're happy to be that thing because we are those two things, right? So,
Yeah.
but we were more concerned about losing connectivity for our existing members and saying, please all try and find a home in case this plug gets pulled. And we're not going to pull the plug. We don't have any intention of quitting care quality. The concern is whether some other major vendor starts with an E, has 4 letters. If they were to disconnect, that we lose a third of the available exchange going on. So that would have been bad. In the process, we then said, all those who are asking us are like, well, what do we do with our existing membership? It's already paid for. I said, okay, good point. We'll kind of absorb that hit in the interim. So it's kind of like almost a It's almost like a trial connection in a roundabout sense, but not really. The intention is to stay here and then, pull out of care quality. The main thing that someone loses from doing that, and it's about the only thing I can think of, is I guess the marketing benefit of being an implementer, like being on the scoreboard as being an implementer yourself. But most implementers we've talked to have moved on from being a member of care quality as a market presentation thing as to a practical service thing, right? It's interop, not care quality or any other brand attached. So they just need the coverage. So we said, okay, just come on over. And most of them can take their time now because they have kind of a dual home where they can start integrating here, but don't have to forcefully disconnect stuff. But they're ready in the event that 6-month time frame, there's an exodus that is accelerated from what we're expecting. We're expecting this to take a year, right, for the kind of the exodus from particularly the Epic sites, but in case it goes faster, we're ready.
Okay. Thank you.
Natural
All right.
hedge.
Yeah,
Ooh, it's 3
absolutely.
o'clock.
Yeah, so thank you all so much. We do have materials that we will be emailing to you here shortly. Please reach out if you have any additional questions. Thank you for your time today.